Good evening, everyone, and welcome to today's virtual panel discussion brought to you by the California Association of Healthcare Leaders. My name is Jennifer Connolly, representing the National ACHE office, and want to thank you for joining us for this session tonight. Before we get started, I do just have a couple of housekeeping items for you. For the purposes of noise control, you are all on mute. If you have any questions or comments during the session, we highly encourage you to use the chat function. If you're on the go during this session, you are able to use the Zoom app. We just ask that when you log into the app that you use the same name that you did to register for the session so that we can match up your credits. Speaking of those credits, this evening's event is worth 1.5 hours of face-to-face credit, which will be applied to your record within 2 weeks after this event. This session is being recorded and will be available back in your MyCHE section of the website within 48 hours. So with that, now I'm happy to turn the session over to the President-elect of CAHL, Darielle.
Thank you, Jennifer. Appreciate it. I'd like to take a moment to welcome everybody to our final event in our virtual series for 2020. This is our last event from this 5-month series. Actually, it feels a little bit longer, but we're excited to, present this last event and welcome all of you to this fascinating topic that we'll be discussing this evening. I would also like to, next slide, please, thank our sponsors, especially our platinum sponsors. I think we're a little bit out of order there. Next slide. There we go. University of Phoenix, Gurnick Academy, UCSF, and AYA Healthcare. So special thanks to them for providing some additional funding to allow us to present the final event in this series for free. CAHL is also, if we go back to the Mask Up, we are also in partnership with the #MaskUp campaign, trying to keep everybody in California and the extending areas throughout the US and globe actually masked and safe, especially given the holidays that are coming in front of us. Just be especially mindful that most of this transmission is family to family, and wear a mask. Wanted to notify everybody that the audience members will be muted during this event, so please engage with us and others through the chat. And, before I, move this along to our host, I wanted to point out a few highlights for the California Association of Healthcare Leaders this year. To those on this event, we have been able, in the last 6 months, really produce 4 qualified education events and 6 face-to-face events in rapid succession every 2 weeks for the last few months. These events have exceeded 600 total attendees throughout the series, and over 35 healthcare leaders have participated as speakers in this series. We, as a chapter, have a membership of over 1,400 individuals, and of those individuals, about 182 of them are members who are CEOs. So I want to extend a special thank you to all our members who are on this final event, and for your support and your willingness to stick through this wonderful 2020 year we've had in spite of all these challenges that we have faced in the state of California. And now let me introduce Andrew Pete. He is a service line director for the Sutter Medical Center, Sacramento, where he oversees operations and business development over orthopedics, bariatric surgery, general surgery, gastroenterology, neuroscience, robotics, and stroke service lines. Andrew received his bachelor's degree in communications from Brigham Young University and a master's in health services administration from the George Washington University. He is the immediate past president of CAHL for at least another month and is board certified as a fellow of the American College of Healthcare Executives. He is a recipient of the ACHE Regents Early Careerist Award and ACHE Distinguished Service Award in 2019. Congratulations, Andrew. And lastly, he also serves on the ACHE National Exam Committee. So without further ado, let me introduce Andrew. Cool and amazing executive leader that he is. Take it away.
Thanks so much, Daryl. Hey, everyone. I wish we could be together in person. I recognize, many of you on the attendee list, obviously, virtual, we'll do the best we can with making sure you all get the content and even the networking. We kept these events intimate, small, on purpose. Definitely feel free to chat. We want to see a very busy chat box going off as our panelists, share their expertise and share their insights in regards to this topic of health equity. As Daryl mentioned, we are, we're in a tough time. I think we're all looking forward to 2020 being over. As we come up to the holidays, this is the last CAHL event of this year. And we definitely want to thank Navi, Kim, Daryl, the rest of the team, Sarah, for all their work, Sachin, for all your work you guys have done to host these virtual face-to-face qualified education events throughout 2020. So we have continued to maintain high quality content, a high bar. So we're thrilled to be with you tonight virtually. We do recognize that it is a somber time for the nation, right? We are now, California, we just hit a threshold of 1 million cases, COVID cases today. So as Daryl mentioned, what CAHL has done early on in the pandemic in regards to our efforts to promote mask wearing, social distancing. Just another reminder, just to reinforce that message, which I know all of you are doing so well. So pleased to be joined with our esteemed panelists. I'm going to go ahead and introduce all three of them. I want them, once I'm done introducing themselves, just to say hi, wave, provide a little bit of thoughts to you about what health equity means to them, as well as just to provide a little bit more background on their organization and how many patients' lives that they see. We have actually a very good representation of the healthcare sector that is represented. So first off, so pleased to introduce Shani Cordero as our panelist. Shani is a lieutenant colonel in the Army. She's the chief operating officer for Presidio of Monterey Health Services. She's responsible for the day-to-day operations and improvement of several primary care clinics, as well as patient care access for over 7,000 beneficiaries. So, she currently serves also as a health IT consultant to the U.S. Army U.S. Army Surgeon General. She's a board certified in the American College of Healthcare Executives as a fellow, and holds 5 certifications, believe it or not. 1 being Healthcare Chief Information Officer, 2 Information Systems Manager, 3 Professional and Healthcare Information and Management Systems, 4 Project Management Professional, 5 an Agile Certified Practitioner. I didn't even know that was a thing, but Shani, it's pretty amazing you're able to get that certification. She received her BA in Chemistry from St. Mary's University, her Master's of Education degree in Instructional Technology from Troy University, and her Master's of Healthcare Administration from Baylor University. And in 2019, Shani was awarded the Regents Award for Senior Healthcare Executive by the ACHE, as well as the 2019 Region at Large Diversity Award. And Shani, happy Veterans Day to you as well. Welcome.
No, thank you, Andrew. And I have to admit, I did go by and get as many donuts as I could from everybody who was offering them to veterans. So appreciate that. And so thank you again, Chani Cordero. So what's really fun about these events is actually representing the public space. And I always say the Department of Defense, we're always hiring. And so, the young careers out there, do not forget the federal space. We have lots of opportunities for healthcare leaders and healthcare administrators. So, Andrew, when think about, what does equity mean to me? I mean, really, I sum it up into three simple words: being respected, being reflected, and being appreciated. Where our differences are valued, not only to our patients, but also to the staff members, that things that make us different is what we actually celebrate.
Well said, Shani. Welcome, and we look forward to hearing from you. Pleased to introduce Philip Chong as well. Phil is the Senior Vice President, Clinical Services for the Northern California region of Kaiser Foundation Health Plan and Hospitals. He has responsibility for regional care delivery, strategy for Medicare and Medicaid members for Kaiser, including models of care for complex needs and vulnerable populations. Phil has regional operational oversight of pharmacy, a continuum of care, which includes skilled nursing, home health, hospice, dialysis, DME, and transport, specialty service lines, mental health, and perioperative services. Phil's also board certified as a fellow with ACHE. Phil, we're so pleased to have you join us tonight.
Thanks, Andrew. I'm happy to be here and happy to be with a really awesome panel. We all have a real passion for this topic, so I'm looking forward to the next hour and a half. And when I think about equity of care, I think a lot of times in healthcare we focus on equal access to care, and equity of care is really more than that. Ultimately, what we're really striving for is really optimizing healthcare outcomes, right? So we can provide access to care, but if we're actually not ultimately changing the health of our members, of our patients, of our communities, then we have a ways to go. And so really, focusing on equity of care is really about understanding what your community's needs are, both from a healthcare perspective as well as from a social perspective, and being able to bring those two things together to, again, really drive those outcomes and ensure that we have the healthiest community that we can.
Great. Thanks, Phil. We look forward to learning about your expertise from Kaiser. Next up, Ken Graham. Ken currently serves as the CEO of Mayview. Actually, Ken, you can add to this because I know there's been some movement there. For Community Health Center, Inc., providing support to the Mayview Board of Directors. Mayview recently completed a major corporate strategic planning and sustainability assessment. Ken served as CEO at really, sophisticated tertiary hospitals, and as a board member or advisor of dozens of healthcare organizations, including, serving at CEO of El Camino Hospital here locally. ACHE presented Ken with its highest recognition, and we're so pleased that Ken is part of CAHL and is active with CAHL, actually. Ken received ACHE's highest recognition in 2011, the Gold Medal for Service. I know Ken was recently achieved the lifetime status as a board certified fellow and ACHE. So we're definitely value Ken's expertise and all he does for healthcare locally as well as nationally. And 2010, Governor Schwarzenegger appointed Ken to serve on the California Healthcare Policy and Data Commission. Ken holds a BS in public health and a master's in public health both from UCLA. So, he's, definitely, we're thrilled to have Ken join us tonight to discuss health equity. Ken. Let's see. Can we hear you, Ken?
Well, thank you for the introduction. I'd like to supplement my introduction with the idea that Mayview Community Health has recently moved its clinics into the FQHC called Ravenswood Family Health Center in East Palo Alto. So our three clinics are still in Santa Clara County, in Palo Alto, Mountain View, and Sunnyvale, but we're now operating as a full FQHC. And just to mention what an FQHC is, a federally qualified health center. It used to be that most people thought those were local community clinics that were operated by their patients. Well, since about 1990, it's become a big business. Today, there are now 3,000 nonprofit FQHCs with 12,000 clinics. serving 28 million patients across the country, or about 8% of the US population. So Mayview itself sees about 10,000 patients a year, and with Ravenswood, about 30,000 patients a year, providing 100,000 visits per year. As far as health equity, I take the notion that it's a fair and just opportunity to be as healthy as possible, or as healthy as they want to be. And this is now closely identified with other issues such as diversity and inclusion when we start talking about engaging with the employees, the boards, and the community.
Great, thanks, Ken. And our last speaker, and we're so thrilled, Dr. Smith can join us, is Dr. Bill Smith, William Smith. He's a primary care physician at the San Francisco VA and director of primary care for the Sierra Pacific Network Regional Telehealth Hub. His overarching interests are in the creative use of technology to improve equity and healthcare access and to enhance efficiency and quality of remote care delivery. He completed undergraduate education at the University of Pennsylvania and returned home to New Orleans, Louisiana, in the wake of Hurricane Katrina for medical school. He undertook his MD, MPH at Tulane and an MBA at the University of Cambridge in UK. He completed his residency training at the University of California, San Francisco in 2017. And in his current role, he's an internal medicine physician with the San Francisco VA as a primary care and with a primary care panel at Santa Rosa VA Clinic. He manages a multidisciplinary group of 45 staff and oversees primary care operations across 13 regional clinics in Northern California and Southwest Nevada. Bill, welcome.
It's a mouthful. I'm humbled to be with this group. Thanks so much for having me today. I've been at the VA now for about 3 years, and I'm really looking forward to talking today about health equity. I liked a lot of the definitions that I've already heard people offer, and I think a common thread is this idea of readily accessible care. One piece that I think I'd like to emphasize is the idea of adapting care at each piece of the care spectrum. I think we have an opportunity to address risk factors related to location, age, ethnicity, or socioeconomic status. And so I think, to me, thinking about health equity, one of the questions I ask is, how can we adapt what we're doing to more effectively deliver care and ensure that everyone's able to access in the same way?
Great, thanks so much, Bill. And just, since we're talking about equity, I do recognize that, Bill, Dr. Smith is the only member of this panelist who is not a board certified in ACHE. So we are going to correct that equity, or that disparity actually, and get you connected with our advancement committee to make sure you get that board certification.
Appreciate that.
So we are before we kick off, again, make sure you use the chat to do your dialogue. We are going to start with the audience poll. We want to get as much dialogue as we can from the audience, even though we are virtual. I was planning on sharing a patient experiences to kind of kick things off, but just to be mindful of time, I want to just go straight to the poll question, just to get your thoughts. And when I ask this question, just respond in the chat, 2 to 3 words. We'll have Navi and her team on the back end compile all the results, and then midway through, we'll just share what those findings are. So the question I want everyone to answer in 2 to 3 words in the chat is, what do you think is the greatest barrier to address equity gaps in healthcare? I'll repeat that. What do you think is the greatest barrier to address equity gaps in healthcare? So again, 2 to 3 words, just enter that into the chat box. And then as you do that, we'll bring back the responses in just a bit. So, as we're talking about, COVID and just the historical challenges we've had with equity. We've heard the bios from each of our panelists, all representing a different sector in healthcare, all with their unique challenges in regards to managing their patient population, which is actually a good section of Northern California. If you look at the millions of covered lives that each of these healthcare organizations that they are all a part of oversee. So Ken, I'm gonna kick this off with you. Why do you think equity is so hard?
Well, thanks, Andrew. And let's first start with giving the audience some support and encouragement as we address this kind of complex and difficult topic. Equity is not something that is taught every day, and it's not something that is a hallmark of our industry or many other industries for that matter. But it is something that we are grappling with to get a better definition, as we can hear tonight, and also to measure disparities in ways that are agreeable, not only to the profession, but also to the people who are affected. One of the barriers has been that it is not a topic that gets paid for. If this was a billable item, we'd be figuring our normal solutions using teams of finance officers and sociologists and managers to figure this out. But the quality metrics that we get from insurance companies who generally talk about managing populations generally fall under something like quality improvement or patient satisfaction. Sometimes our boards will say, how's your employee satisfaction? And we'll add that in there. But our organizations are not really designed to deal with equity. We're usually designed for production, seeing patients, putting them through exam rooms, doing surgery, sending them home. The idea that somebody would be offended by how we treat them or talk to them, it really doesn't occur to us much. It has been, even in medical schools, not a high topic. Generally, doctors are taught to be available, accessible, and affable, but that doesn't mean sensitive or totally aware of equitable disparities. So for all of us who are about to get into this in a bigger way tonight, I'd like to provide you with support for the courage it takes to enter into this conversation and the risks we take organizationally and personally and professionally. It is not easy nowadays, especially with polarized politics and also a lot of different populations to be able to have these difficult conversations. And that's because there are a lot of issues that impede or impact the healthcare industry. It's kind of like solving a big quadratic equation, because we not only have to worry about healthcare and how we treat people, how we employ people, and how we engage people, but we also have to figure out how we're dealing with the employment issues around us, the pandemic issues around us, the issues of quality education, safe housing, safe environments. And this is then a thing that requires collaboration beyond our doors. This is not something we are built very well for. Generally, we support community development through grants and volunteerism, not necessarily through direct program enhancement. And then, of course, we have issues that have to do with leadership, decision-making, and internal cultures of our own making, and some that we've inherited. And then, goodness sake, we're going to be passing on some, so we want to be careful and appropriate with what we develop. I'd like to open this up to our rest of our panel here. This is not meant to be a keynote speech, but the idea being that there's plenty of reasons America is aware of these topics, the issues of Black Lives Matter, the issues about the disparities in healthcare outcomes. On the other hand, who's better to do it than ACHE? We got 40,000 leaders that can start to address this in an effective manner. It has not been something that we've been terribly effective at as an organization. You read in your health policy from ACHE that our glass ceiling is still pretty much intact. We only have about 9 or 10% women in CEO roles. We've got a lot of diverse populations in our membership, but we have not progressed very dramatically over the last 20 years in busting up the model that it's a bunch of women workers, 80% women workers being led by several thousand men. So we do need to explore not only the racial and ethnic and community issues, but also the issues of gender and equal access and development opportunities.
Thanks so much, Ken. I mean, it is, it's hard to imagine as we're approaching 2021, we're still trying to figure out how do we create health equity, equal access to healthy lives, right? To allow everyone to live as healthy as they can. Phil, Shani, Bill, any insights here on why you think it's just so hard to grasp, at equal access in regards to health?
I'll jump in, Andrew. I think one of the other things that when you think of larger health systems that we struggle with is that we like solutions that can be standard, that we can deploy over large populations, right? So kind of you need to find the magic bullet that then just solves your challenge. And I think when you think about disparities in health equity, health is a very local thing. And so it actually takes the time to really unpack and really understand what's going on in a local community with a local population, and that there might not be that simple solution that's going to work everywhere, but that you have to go in with, I think, humility and an open mind and be willing to engage with populations where you see disparities and really come up with custom solutions. And again, I think from a healthcare perspective, we have typically wanted to find the best practice and then just say that's going to work everywhere.
Shani, Bill, any thoughts? Shani,
Yeah,
go ahead.
As we talked about before, why is this so hard? We've been trying to go after this for decades, right? And honestly, when I really think about the heart of the matter, I just think that our country hasn't decided, is healthcare a right or a privilege? And because we haven't been able to answer that question, then it's hard to answer the question, is equity something that's important? And so I, believe that a lot of healthcare organization is starting to answer that question for us, and they're taking the time to do initiatives that will reflect equity because we haven't been able as a country to decide what direction that we have to go in. Are we better than we were 50 years ago? Absolutely. Do we have work to go? Absolutely. But I think that we have, as a community, come together and decided what direction we want to go in.
Yeah. Thanks, Shani, for that. And going off of the organizations and what our organizations are doing. Bill, can you talk, maybe just talk a little bit, share to the audience, what methods, what strategies is your organization using to strengthen care delivery, to the vulnerable populations, that we serve?
Yeah, so, and I agree that this is a hard issue. And I think some of the trouble with it is that there's so many different factors influencing disproportionate access to care, disparities in access to care, that I agree that it can be hard to find that sort of magic bullet solution. I'll just zoom out for a second just to provide a little bit of overview in terms of the VA. So it's a 21.6 million member health system, spans the entire US. It's in every city, every territory. Half the population is over 65. About a third live in rural areas. So a much bigger proportion of the veteran population lives in rural communities, about 30% versus 15% of the non-veteran population. And so that just sort of paints the picture of the organization overall. I think some of the main areas where VA has been working to strengthen equitable access to care has been, one, in the use of technology and strengthening education infrastructure, but also thinking about targeted outreach to individual high-risk patients. And so if we think about it in the context of COVID-19 and this pandemic, I think of sort of four buckets as your main contributors to healthcare equity, or what you might think of as determinants to access. I think of those as ethnicity, socioeconomic status, age, and geography. And I think during COVID-19, one of the things we've seen is a really rapid change, and at least an opportunity to change some of the paradigm that we've had for a long time as fixed determinants of access. And one of those is geography. So with COVID-19, although we've seen a lot of really negative pieces in terms of having to close down clinics, disproportionate impact of the pandemic on communities of color and communities in Native American areas in the country. Geography, though, starts to become something that has the potential to become less relevant. We've seen VA send over 60,000 iPads to people across the country that have built-in cell service ready to go. There's training programs with staff at each point, whether it's clerical staff, nursing staff, or provider staff, who've been able to work with patients to train them in using video technology to access care. And so while I think that there are many terrible things that have happened with this pandemic, one opportunity that's come out of this is being able to see people remotely and reduce that amount of time it takes to go see the doctor. We certainly know that in this country, one of the things that we struggle with is how long it takes to access care and how fragmented it is.
I think so. Obviously, the VA has been at the forefront in regards to technology, whether that's electronic health record adoption, whether that's telehealth visits. I mean, you definitely are at the forefront there. So, hearing that, continuing on with that history of providing technology or using technology to ensure equal access to the VA membership via the iPads and things like that. That is interesting to hear. Phil, Ken, any thoughts? What is Kaiser doing to address, the health equity within the Kaiser patient population?
Andrew, I mean, I think a lot of it is what Bill talked about in terms of figuring out new ways to really provide access to our members, and especially through video visits and other remote visits, so that folks can get care when they need it. I think the other thing is really trying to understand where we're seeing disparities result from the pandemic, and really making sure that we're starting to address in a way that really reflects both the kind of racial and ethnic differences, the linguistic differences and cultural differences of our populations. And that's a lot, we're doing a lot of that through community organizations. So a great example is contact tracing. We funded with a grant of $63 million to the Public Health Institute to really support contact tracing, not just for Kaiser members, but really for the community. And that tracing is really being done through community-based organizations who really are embedded in our communities, who then can really make a connection with folks and really educate and really be able to move the needle much more so than we could possibly do as a health plan.
Yeah, no, well said, Phil. I think it really is kind of that grassroots organization that really touches and makes the change, right? I mean, our patients, California, if you look at it, I mean, our uninsured is actually very low, in the state of California. So it's not necessarily an insurance issue in regards to access. It's really, what is it that we need to do to make sure when patients need healthcare, they're actually motivated to go to the right location, right, and actually make a concerted effort to get there versus delay care until it's too late, which we're seeing obviously with COVID quite a bit. So with the COVID pandemic, Shani, what's your organization doing? Given the pandemic, what's changed with your organization? What's been identified as a need to change in terms of care access?
Yeah, so just to give a little bit of history, or just an overview of our organization. So again, I'm part of the Department of Defense. And so my beneficiaries are essentially active duty family members, active duty and their family members, and then also retirees. So we don't really serve veterans unless they are Medal of Honor recipients or they have an entitlement to visit our facilities. And so my population is a little bit different than most. Will has the over 65 and I have like the 20-year-olds. So, our care access was a little bit different with COVID. I would tell you that what's unique to us is that we are located in Central California on the coast at the Presidio of Monterey. And we're honored to serve the Defense Language Institute, which is a schoolhouse that teaches all the different languages that our active duty officers and service members need to know so that they can provide those translation services all over the world. So we were actually, I would say, alerted about COVID probably as early January, more so than the rest of the country, just because during the holiday season, we had a large number of the Mandarin schoolhouse that actually go home for the holidays. And there was concerns of this unknown virus that was over there. And so what I said, what the first thing that actually changed in my organization was actually how we communicate with our community. And so, many times, I think in healthcare, it's kind of like a pull system in a sense where we push the information, but the patients have to go and pull it down. And I think what we change first and foremost is the push way of communicating with our beneficiaries. And so before we had like passive websites and, social media that we kind of, put stuff out there, but it was really incumbent of our beneficiary to come to us for information and ask the questions. And so this time around, we were far forward leaning. We were telling our beneficiaries what to expect with COVID. We created our COVID pre-screening tent, very quickly. We work with our community partners to talk about what happens if you have an affected staff member. And so I think that's something that we did really well, is letting our beneficiaries know what to expect and how to respond during this pandemic. And then I'm going to mention virtual medicine, just, like how William mentioned, is that, that is where we really change fundamentally how we do some of our health services. I'm essentially primary care, right? And so the folks that come in for me is, coughs, scraped knees, and, chronic back pain, right? And so we learned that some of those ailments can be done virtually. For the government space, mind blown to be able to actually see our patients virtually, in a sense, or even if it's telephonically or a video visit. That is a different culture for us, because our culture is hands-on. I have to see you in order for me to know that you're actually who you say you are, and you're actually injured like you say you are, right? And so that was a big change for us, switching to a virtual platform. And, with the ONC making the changes in the sense of what platform you can use, in a sense of using, Zoom, or some of the not necessarily HIPAA compliant. Zoom is HIPAA compliant, but some of the other ones like iPhone or Siri or whatnot, that was mind blown for us to be able to use something, because we're the government. I have to, have two-factor identification in order for you to, be able to talk to a provider. So that was really different for us. But, what we found the most, and I think this is going to be sustaining for us, is meeting patients where they're at. And again, we were very traditional, very conservative. Hey, our clinic hours are from 7 to 4, that's it. After 4, go to urgent care to ER, not our problem, right? If you can't come to us, not our problem. And so we, fundamentally have changed our model in a sense of, having these virtual appointments, allowing the patients, if they need to come in, then they will get pre-screened in the morning, and then we would create an appointment for them. For us, one of the biggest difference was, again, so my population is active duty. I need our folks to be able to be seen quickly as possible so they can get back to the mission, and whatever that mission is. And so if it's going to school, or going to go fix a generator, go fix a tank, whatever that mission is, I need them to get there quickly. And so we changed how we deliver care, in a sense that it's not okay to actually have them in our facilities for 2 or 3 hours at a time. As we get to them, now it's like, nope, we need to be able to shorten the time that they're in our facility.
Yeah, well said. Love your energy and passion, Shani. It's great to see and hear. And thanks for describing really the Department of Defense model in regards to healthcare delivery. Especially, I think with all of our organizations, we're probably can say, when patients hit our doors, we generally do a good job with managing any illness or ailment. The challenge we deal with is when they actually leave our systems or leave our area of reach. For example, at Sutter Medical Center, Sacramento, as you mentioned, if someone comes in with some kind of a pain ailment, we'll do a good job managing that pain. What we lose line of sight of is when that patient gets discharged, for that follow-up. We have no idea whether or not that patient's actually showing up for their follow-up care visit, whether that's at a health clinic or whether it's back in through the DOD. If it is a patient that ended up coming through our ER, we really don't have a good line of sight of whether that follow-up continued care is occurring. So, again, that's kind of an equity issue as well. Ken, what are you seeing at the health clinic side? You're right on the front lines there in regards to the health disparities. With these health clinics, usually, serving the most disparate population in our communities. Ken, what do you see, and what's the organizations doing to try to solve this issue?
Well, we had a rapid turn to virtual visits when the pandemic started. We did it in like 2 days, but we didn't use the traditional channels. We used Zoom healthcare, and we used, of all things, FaceTime. And why was that? It was because the patients who are poor or the patients who are diverse all have cell phones and talk to each other. And so we would plug it into their network and getting their feedback through things that was comfortable to them. Now, it was the national emergency that allowed us to do that. So up until the March, we weren't allowed to break HIPAA or do any of these kind of, quote, non-secure communication methods. But of course, the patients have been using this for years. And yet the idea of applying it in the workspace or the care space was pretty novel. The other thing we did is we changed the functions of our sites. We had one for safe care, if we would call it that, the other for sick care. And then we took a third clinic and remodeled it while we were in the pit, if you will, of a race car. We pulled the clinic offline and redoing the air conditioning in the front door to make it more accessible for ADA and handicapped patients and that. But we've kept going on trying to work on registration and things that don't require exam rooms. We work with whole person care programs with the county and insurance companies. And we're trying to continue to develop further the engagement of the social workers and mental health folks, and eventually getting back to dentistry. We do now with Ravenswood have access to a mobile or a part-time access to dentistry. But when it was running with full COVID, prior to COVID, we were seeing 21 chairs a day working all week long. And now we're down to just one room or so because those rooms all have to be remodeled and new air conditioning put in to allow for dentistry to be run. But other than those disruptions, I think we've been very impressed with how our caregivers, our doctors particularly, and the patients have been accepting virtual visits. This technology has been around for 20 years, but it's only been premier here in the last 6 months. So thank you very much, William. We appreciate the leadership you're showing in that area.
So I'm gonna pause here, and I definitely am looking at the chat too. Make sure you write any questions you might have for the panelists. I do see one comment in here regarding the current reimbursement system rewards the current state. All right, so let's build off of that. Say you say we have a Medicare for All program, for what is it, 330 million plus Americans. Would that solve the health equity issue? Phil, let's start with you, Phil. You're kind of in that integrated Kaiser model. Would something similar for the whole U.S. would that, in regards to if the reimbursement issue was off the table, would that solve the equity issue?
Absolutely not. I mean, it's a part of it, but I think it's. And I'm kind of looking in the chat. There are a lot of really great comments on, what the barriers are, and so again, access is a key part of it, but there are systemic issues about how we've, built healthcare, how healthcare connects to people and connects to communities, and so access is just the first part.
Great, thanks, Phil. Another question. Looks like, do you feel that telehealth has improved access? Great question now that we've seen the telehealth visits increase significantly, right? And it's the new norm, right? It's not going to go away. I don't think CMS is going to revert to pre-pandemic regulatory stance on this. Has your organization seen improved access and equity in regards to the telehealth technology? Let's see, let's go, Bill, let's go with you. What's been the increase pre and post COVID, in regards to the telehealth consult visits?
Yeah, I'll be really interested to hear other people's experiences as well. We started out doing a lot of coverage to clinics directly. So providers are sitting here in San Francisco, seeing patients in remote clinics, often rural community outpatient clinics. And we'd see patients over video, and the experience was intentionally very much the same for the patient coming into clinic. Since COVID, it's been and I would say that probably represented about 80% of our visits, 20% telephone. And then introduced the pandemic in March, and that really shifted. And so those in-clinic visits that we were doing before shifted to video to home and to telephone. And so VA-wide, the proportion of, if you look at the visit breakdown from face-to-face, in-clinic video or video to home, and telephone is the other one, the vast majority right now are over phone. And so even though the VA has had a real, I think a lot of foresight in terms of thinking as an institution, how do you really distribute this technology across a really large and diverse patient population, but also a large provider population, it's also faced a lot of the challenges that other organizations have had. And that's, anytime I think you have a rapid change to an entirely new modality, I think you'll see that happen. So I'm interested to hear others' experiences. I do think it has improved access though. I think if you take out the pandemic, there's a real opportunity for it to have lasting impact.
It's interesting. I mean, even in our backyard, earlier in the year, I read an article from Venice Health, what the system's doing in regards to home ICU, using technology to actually allow, critical care patients to actually receive ICU treatment in their own homes. Is this the new norm? Is this where we're going in regards to healthcare? Is this, and does this model help with that equity issue? Or is it going to make a greater gap in regards to our patient population, being able to access those sorts of technologies? So, Shawnee, go ahead.
Yeah, so I mean, it's interesting because I agree with you. We talk about the video visits. Usually when we're talking about virtual health, we're talking about video visits because we always have some form of virtual if you talk about telephonic visits, right? But if you're just saying video visits, that's a little bit different. But I agree, my population for the most part is, young 20, 30-year-olds that all have, $1,000 smartphones, right? And so them having access to us is pretty, pretty easily. But, I talked to a fellow CIO out in northern New York who borders the Canadian border. And she mentioned about the broadband in rural communities is not there. And so, a lot of these areas do not, have the ability to have a video visit just because they don't have the bandwidth or the cell phone coverage or, even the Wi-Fi internet coverage. And so, I mean, I'm in Monterey. I'm like 60 miles from Silicon Valley, and I am devastated over my terrible internet here. So yeah, definitely, access to this, high speed, fast internet is definitely not everywhere, and that is an additional barrier. And then like one other note, because we've been talking about it now in the schools, right? And so, you have a lot of children that are in these digital deserts and, talk about how, I think there was an article where these, two young, children were in a Taco Bell parking lot, to be able to get access, Wi-Fi access, so they can go to school. And so I think this is more prominent than we think, especially if you live in larger cities.
That first full question. The question, what do you think is the greatest barrier to address equity gaps in healthcare? Navi, Sarah, can we put up the results from that poll? Are you guys ready to show those results? Let's see. All right. So obviously, the larger the word, the more people voted or put that in. Is that correct? Is that a correct correlation?
Correct.
So we have affordability, access. Is that equity? It's kind of right behind my video. I can't see it. Let's see. Yeah, equity as being looks like the top three. So with the first one being affordability. So let's dive down into that a little bit in regards to affordability. The Phil, let's start with you. Are these results, are these surprising to you? Is this what you would expect to see from this group? Oh, Phil, we can't hear you.
I think our attendees have done a really fantastic job, like summarizing the state of the field. I think these are all components of really why it's been difficult to tackle this issue. And I think affordability is, again, to one of the earlier questions, it is an important aspect of it. But if you even look amongst our populations that are insured, so again, it has nothing to do with their ability to obtain healthcare coverage. You still see disparities. And so, for example, if you look at COVID-19 and how it's impacted, communities of color, in particular the Latinx and Black communities, in California disproportionately, you see that same pattern happening with our membership at Kaiser. And these are all folks who have coverage, and at Kaiser, your coverage really, if you're a member, you're a member. There's really not a tiered system of the care that you can access. And so again, affordability, I think, is kind of the foundational kind of table stakes. Like, if you don't have healthcare coverage, that's a huge barrier. But even if you get past affordability, there's still disparities. And so then you start to unpack all these other things that are here up on the screen, and some of it is in our communities around really, kind of the social needs, the social determinants of health. It's frankly trust of the healthcare system. It's how we communicate with those communities. And so, really there's kind of this community aspect of it. And then there's the other piece, which is the healthcare system, which is to say, as leaders, do we focus on health equity? So do we build systems within our within healthcare that actually drive results? So we have, I think, at most of our organizations, great quality systems that measure really important outcomes for our members. How many of us actually use that really mature data collection, data analysis, driver determination, and kind of quality improvement to drive equity improvements? How do we use that to actually improve disparities of care? And so I think there's kind of a combination of things, both kind of in the community, but also within our own health systems, where we don't focus on disparities of care in the same way that perhaps we focus on other things, because these other things have been in the industry for a long time. Surgical site infections, we know how to measure that, we know best practices, but I think when it comes to disparities, where I think we're very early in understanding what drives disparities. And so it's hard to measure, it's hard to benchmark, it's hard to know what the right thing to do is. And so I think it's on us as a system to figure out, how we advance our practice.
So just, if I may, just kind of drilling down a little deeper with the Kaiser model, because obviously Kaiser is the largest not-for-profit health system in the U.S. and has a great brand and culture in regards to managing your patient population very, very well in regards to outcomes and costs. So affordability, obviously, Kaiser does a great job. What about access? Can you, access is kind of that second bullet. Does Kaiser do a good job with their members accessing the healthcare that they need? And when I say that, is that access, is it local? Do they have to travel distances? Do they have to go to certain locations to be able to access that certain care? Does it take a little longer for them to access, for example, maybe some specialized care? Is access a kind of an issue or creating a disparity within the Kaiser model? Bill, in your experience?
I think, again, it's very local. And, we as a health plan are held to the same standards that other health plans are around, network adequacy and ensuring that our members have geographically available care. And I think to Bill's point, we've seen an enormous surge in virtual care as well. And so as an example, this kind of change in access last year and all of 2019, KP, we did about 100,000 virtual visits. In the 6 months after the pandemic, so you're going from March to September, we did over 2 million virtual visits, right? So we've been able to figure out different ways to provide access. And again, you might argue that a virtual visit doesn't take the place of all healthcare, but it is a way for our members to connect with a physician, with a provider, at the very least to get started on the path to care. And so access, again, is a important foundational piece, but in and of itself doesn't solve the disparity issue.
Yeah. Now, Bill, going with you, we kind of been talking about telehealth quite a bit, the technology, and I know there's a question in regards to, well, what if people don't have access to the telehealth technology? We know, can you speak to that, Bill? Can you also speak into, okay, we know the number of telehealth visits are significantly up. Do we have data in regards to those visits? Do we have outcomes data on whether those telehealth visits are actually making an impact from a quality outcome standpoint?
It's a good question. I mean, I think we've seen a lot of the change and reliance on virtual visits really just take place over the last 6 months. And so outcomes data that's really long-term and good quality, I think are lacking. But what we do have are those more near-term proxy measures of saying, okay, have we been able to validate different pieces of the physical exam and say that it seems like this is just as good when you're comparing it to physical exam in person and in a lot of different disease states, particularly musculoskeletal and neurologic ones, people have been able to say, yeah, this is pretty close. And in dermatology, people have been doing this for a long time as well. I think when you totally revamp how a population is thinking about accessing care, that you have to have long-term analysis to really understand what the impact is going to be. On the first part of the question, I think the affordability side just continues to be an underlying theme here. We can only modify so many pieces of the care spectrum when we're just talking about access of your visit. But if you don't have internet access that's of sufficient speed to be able to do a video visit or have access to a smartphone, and I don't think those are givens, then you come back to a real question of, okay, are we only able to modify a certain piece of this curve essentially? And I think it's really going to be crucial over the course of the next few years as we think as a country about what we want to do on these issues. I think we need to think about universal broadband, and we need to think about the possibility of, or at least ask the question of, what are we willing to pay for as a country to make sure that there's a standard or a minimum level of care delivered to everyone.
Well, that's a good point too, Bill, what you mentioned in regards to, well, even if folks have the technology, maybe the connection's not strong or you lose the feed. Are you seeing many of that type of experience? I feel like even within my work environment with Zoom and WebEx, I feel like every other meeting, there's some kind of audio video issue, and that's just here locally in a network that supposedly is, high quality, high speed, et cetera. Are you seeing a lot of, challenges with actually connecting to your patients? Is there a lot of drop off there?
I think it's pretty similar to my Zoom rate, to be honest with you. If I'd say in a third of visits, I have some sort of interruption, I would say it's similar, and that we would like to get back to having, more access with face-to-face, but during this intermediate period, it at least has been helpful to have some of the restrictions relaxed on what platforms we can use so that we're not just relying on one provider.
Connie, what about you? All those 20-year-olds, is there a certain Is there a certain phone that connects better virtually with all those visits? You know, Samsung, iPhone, what is it, Shawnee? What are you guys seeing?
I wish I knew because I would go buy stock immediately. But yeah, but similar to here, because again, I'm Central Coast and this area doesn't really, believe it or not, doesn't really, it has, broadband or whatnot, but it doesn't have the cell coverage that you think it would have. And so, one of my initiatives actually is that our service members are, they're in classrooms at the school. And so we're looking at actually having care rooms. And so, we're working with the dean of each school to actually designate like maybe an old conference room or something. And we're making these care rooms, and they're going to have a computer, and they're going to have a hardwired telephone. And it's so that the patients are able to use that instead of relying on their cell phones, because we're also having the same problems of just coverage.
Yeah. Well, and one final question, just to close this poll dialogue that we're having. I see there's a question here. If we assume the top 3 determinants from the chat were access, cost, and education, the big ones, how would we collectively begin solving those issues in our current fragmented healthcare provider system where patients can change health plans yearly, right? And we just had open enrollment for Sutter. So exactly right. These health plans and even the plans themselves are changing in regards to what's a covered and not covered benefit. And any thoughts here? Let's start with you, Phil.
So, I think that, again, huge kind of societal issues around, if you want to get back down to healthcare coverage, and we want to kind of tackle that question, then I think it goes back to what Shawnee started out with, really kind of deep fundamental question, is healthcare a privilege or a right? And, are we going to tackle that as a society? And, we have healthcare that is really, for the most part, tied either through a government entitlement, Medicare or Medi-Cal, for specific populations, or to employment. And so are we going to go with a different model where our society is willing to, approach healthcare coverage from a different perspective? So let's so that question, we could spend an hour and a half or a couple days, kind of going through that question. So let's kind of set that aside and say, but once you get past the coverage aspect, and let's say that everybody has kind of essentially the same coverage, so no high deductible, kind of plans that kind of don't incent the right kind of preventative care behaviors and plans, then again, you get into the issues of, what else drives health? And health is driven, I think increasingly recognized, it's driven by social determinants. And social determinants are driven by economic opportunity. They're driven by racism. They're driven by your life circumstance. And so those are all things where then as a healthcare system, we have to ask ourselves, if we're going to solve those, which are kind of have been outside our normal bounds of healthcare, are we ready to go there? And I think that you're seeing Kaiser and Sutter and, lots of other health systems begin to really take that responsibility, because we're saying, what, if we are about health is more than seeing a provider. Health encompasses a lot of other things as well. And our providers are faced, I'm sure, Bill, that you're faced with, when you see a patient, not just their medical issues, but their social issues. And you have to unpack all of that and help that person figure out how they're going to live their best life. So I think, again, healthcare coverage, huge issue, but even if everyone had that, there are still these other structural issues in our society that we have to tackle.
Another policy debate that we can continue to have, which will take us in a different direction. But I'm going to pivot. Well said, Phil. I'm going to pivot to you, Ken. Here, ACHE, CAHL, obviously we're a membership of healthcare leaders, healthcare executives, clinical leaders. Phil, or Ken, excuse me, Ken, with your experience in healthcare, for all these years, do healthcare executives do you feel like they have a clear and accurate picture of what's going on in their own organization, you know, from an equity standpoint? Do they have a good pulse of what's going on? And Bill, I'm going to ask.
Actually, I think the answer is never enough.
Yeah.
And you can start with just being on the ground in a hospital where the CEO is there for 10 hours. You still got 14 more you're not covering. There's always these questions that come up about the neurosurgeons will tell you the care at the night shift is different than the day shift. There's the issue in the military that I'm aware of that, you know, how does the admiral in San Diego know what's going on in the destroyer that's driving through the Gulf of Alaska? So these are problems that are just primarily due to physical access and then the initiative to get in front of that. In a hospital, usually we have shift supervisors that are supposed to be reporting upward. Executives are supposed to not only be doing physical rounds, but are supposed to go talk to the patients, wouldn't you know? Not a very high science yet in our industry, but there are some administrators that think that's the most important part of their job is to go check the product. And actually it's kind of fun, but there's techniques, if anybody says you should, I can be happy to take those offline. But there's other techniques that are being developed. One of them is the idea of doing a set of bottoms-up projects, like we did with quality improvement in the 90s, and some of the things we've been doing with empowerment in the last 10 years, where groups of people are brought together and then are to write reports or bid for funding of a project, kind of like a rapid response team regarding an issue of patient care, patient access, insecurity, or various kinds of equity problems. And those are probably better than coming from the C-suite itself. We know that that's a somewhat isolated environment. The CEO is only there a third of the time. The people on the front line can work with each other, you know, broader exposure and create work teams that can bring that forward. That also is somewhat limited because it doesn't get to be universal. So just like, I don't know, about 20 years, the Admiral in San Diego that I was talking about developed a electronic assessment program for his ships in the Pacific. So the 7th Fleet was reporting back work reports electronically, confidentially, back to the human resource people in San Diego, and they could tell them that the destroyer in the Gulf of Alaska was having problems on the Saturday night shift. So those are technologies that have been around for a while. But we can see that this is now being described in a more articulate way, even by the US Census. They call them pulse reports. And we can now design things that create pulse reports from the night shift or from the emergency room or from the social work department with confidence and confidentiality. Whether the science will ever catch up with the idea that we need to be in relationship to get honest and candid and consistent communication is, I think, yet to be proven. But you can see in some of this equity thing, some of this stuff is giving people equal voice, equal access, and an impact in what their ideas are for creating more of a just and effective system.
Thanks, Ken. Well, Bill, let's go to the on the physician side. Do you think physicians, have a clear and accurate picture of the patients that they manage from regards to health equity? Knowing that physicians typically would have thousands of active patient lives that they're seeing. Do they have a good sense of whether those patients are really getting equitable care?
Probably not, right? I think that part of why we need to have panels like this is because we're not doing a good enough job of this. I think this really comes back to EHR interoperability as a real driver of outcomes and equity in healthcare. And if we don't have EHR interoperability, coming back to that question before about how do you care for people that are changing between lots of different plans, if you don't have that kind of data sharing, we're going to be really stuck in terms of really trying to get a picture of how the patient has accessed care and their care across the full spectrum. I think we're getting better though. I think I can't speak to every system and every type of care, but I can offer like 2 brief examples. I think the trend is toward better real-time analysis of patient cohorts and access patterns. And one example in primary care is looking at groups of patients recently hospitalized or high utilizing patients and trying to understand, okay, what are some of the things that we're not providing for these patients that's making the need to access the healthcare system more or access the ED more. And in March, when we transitioned to so many more video visits to home, we said, okay, with one of our local dashboards, trying to say, okay, how are the patterns of access changing based on patient age, demographics? And so we started looking at how age groups were changing for different visit types. And I think undergoing that sort of continued analysis for different providers, different teams, just has to be an ongoing part of how we're delivering care going forward, and really is going to be important for making sure there's an equitable allocation of care across the population.
Thanks. Shani, Phil, anything else you both would like to add at all with these questions? In regards to healthcare, Kim, when you were talking, I was thinking about, obviously, and working in a hospital or part of a health system, you hear a lot about, value-based care, right? Are we providing value to our patient population through, decrease in costs and increase affordability? Is that what we're talking about? Is that getting us towards equitable care, with those value-based models, or are we just really kind of shifting cost around?
Well, there's some of that. I think that maybe when it gets to this term of affordability, as far as the underserved, I would say the uninsured or the poor people that are on Medi-Cal, is that we begin to realize that they're affected by other people's policies. And it relates to the term of insecurity. So it's not just affordability, it's accessibility to payment when it's needed. So if you're living in a camper on the street in Mountain View and you got 3 kids and the city passes an ordinance that says we're not going to have motorhomes in Mountain View anymore, what does that do to secure housing, schooling, employment, and safe environment? The same thing about the comment that was made earlier about the system's built to sustain itself as it is. Well, naturally, that's a self-defense mechanism from the human being, but it also creates a conflict about what to do about who's in charge of the stability. Is it the regulator in Washington? Is it the insurance company that changes the plan? Is it the employer who threatens to move from Blue Cross to Kaiser because they're cheaper or more expensive or better or whatever the issue is? So the issue of insecurity creates a lot of anxiety. And you go home at night and you watch the news and they're talking about doing with the ACA, or you see this idea that plans are changing and you're not in charge or have no control over what the plan is going to be, or that coverages are changing, and so we have lots of issues to do with Planned Parenthood and the idea of support for mental health and other things that are very vulnerable in the health system. And on those annual reviews, those programs can be affected. So I think that one of the things we could contribute to is to be aware that it's not just access and affordability, but it's also the sense of, is this going to last, or will I be able to participate? And those insecurities are very real, and they're frightening to a lot of patients who are afraid of the terms about what's going on with immigration, what's going on with public charge, and what's going on with these health plan changes that are obviously fluid in a pandemic.
Thanks, Ken. Well, let's get our last, our final poll question up. I want to get the audience, and thanks so much, audience, for being so active on the chat. I'm not able to keep up, but I do see a lot of dialogue going on. So thank you. Please keep it coming. Last poll question here. So this one's a little easier. All you have to do is click one of the icons here. So what obstacles to health equity would you prioritize? We had a lot of dialogue regarding, okay, so what are the barriers? As we talk about optimization, or excuse me, prioritization, what do we tackle first? What do you feel is the most important to really get all our collective efforts to focus on creating solutions to. So take a minute here. There's the list of obstacles that were identified, and this comes from the Robert Woods Johnson Foundation article on what is health equity. So we'll just give it a few more seconds here, and then we'll close this poll when Navi, if you feel like we have enough response, you can then share those responses with the panel, and we'll have some dialogue in regards to what we're seeing. All right. Well, thanks everyone for participating. So highest top three. So affordable healthcare insurance. Number two, poverty. Number three, quality education and housing. As really with the highest priority in regards to our efforts right here on affordable healthcare / insurance. So, Shani, does this surprise you, these results right here? We did spend a lot of time talking about affordability, insurance coverage. Is insurance coverage the issue here in regards to solving the health equity? What do you think? What's your thoughts on looking at these outcomes, these results?
So definitely, it's not a surprise at all. And I mean, again, going back to Phil's point, it's just about the social determinants of health. I mean, in the end, yes, we always have the iron triangle that we're looking at, which is access, cost, and quality, right? But there's the other stuff, right? So those 12 factors of, social determinants, definitely plays a larger role. I would say that, I think what's different now than maybe 30 years ago is that we're actually acknowledging that. And so a lot of healthcare systems are going after those factors. I mean, I've seen in the chat of some of the organizations where people are doing to get after those factors, those food insecurities and housing insecurities that Ken mentioned, because, yes, I worry about my gallbladder, but right now I'm worried about where I'm going to eat tonight. Right. And so, as these, health systems are looking after this so that they can get after the whole person concept, hopefully eventually, we'll get to a point where we can eliminate some of those other barriers.
So that's interesting on that list. They noticed discrimination wasn't voted on at all, which I thought was kind of interesting. Knowing that, working on a hospital standpoint, there is discrimination that occurs, especially depending on the patient's insurance plan, right? And what the payer is, and I know that's the case on the long-term care side too, in regards to what the patient insurance is, what the patient's co-insurance is, so there is some level of discrimination that is occurring based on the patient's plan, right? So how do we, from a prioritization standpoint, how do we tackle that? Phil, what has Kaiser done, to manage their patient population who, maybe doesn't have, as much of an income to pay for those high Kaiser plans? What are some of the solutions you guys have figured out?
Well, I think, we're a health system, so we take care of anybody who walks through the door, right? So anyone who walks into our ED, we have an obligation as a community resource to take care of those members. And then it's about helping that person get to the right, resources to kind of sustain their health. And so I was kind of chatting with folks in the chat around, one of the initiatives that we're launching at KP, which is, we've been rolling it out over the last year, which is Thrive Local, which is both a resource directory and electronic referrals to community-based organizations that support the very things that Shani was referring to, things like housing, food, transportation, legal and financial counseling, all the things that, again, we don't take for granted for those of us who are employed and are financially well off, but for others who don't have those financial resources, these are the things that get in the way of health. And so, being able to connect patients who in a time of need are probably not well positioned to navigate a complex system of who can I go to? Do I qualify? Do they actually serve where I live? These are the things that, again, health systems and health plans I think broadly, again, not just KP, but I think I'm seeing this everywhere, are realizing that this is an obligation from a community perspective and from a health perspective, that we have to help patients be able to navigate these social determinants, or we're actually not going to be able to help their health.
Just to wrap this up, Shawnee, I'm going to go final question to you and then open it up to the panelists as well as the audience for any final questions. ACHE, they obviously this is an important work across the college. They have a public policy statement in regards to health equity. And in that statement, which I encourage everyone who's on the call to go back and read it and reference it. It's in the handout material. But ACHE, Shawnee, believes that fostering inclusive environments will help reduce disparities in care and improve quality for all. Why do you think inclusive environments reduce health disparities?
That's a really good question, Andrew. Thank you for bringing that up, because essentially, the better a patient is represented and understood in a nutshell, the better the treatment. And so, we know that healthcare services have to meet all of those different unique challenges that makes us different. And, what Philip mentioned earlier, the social, the cultural, the linguistic areas that make everybody just a little bit different from each other. And so we can understand that. We know, statistics show and continuing to show how a diverse workforce, a diverse organization has better outcomes, even just either patient quality outcomes, but just even in the business of profit and whatnot. And so, we have to go after those areas just so that we can take care of those patients that we're privileged to serve. I like to sometimes think of, use the military as an example, because you think that we're a pretty homogeneous, organization, and that all of our folks are the same. And I have to chuckle a little bit, but, maybe about 10 or 15 years ago, we had a scandal, and we call it the Walter Reed Army Community Hospital, or Army Hospital scandal in a sense. And essentially it was some of the housing situation that the service members that were living in. Well, historically, the Army Medical Department was in charge of taking care of these warriors, these infantrymen, the artillery, service members. And so the Army actually recognized that perhaps we need to have different leaders in charge of these warrior care units, where before it might have been docs and nurses and medical administration folks. And they actually said, you know what, I think for these warriors, the people that lead them, not their care is still handled by the care teams, but the leadership of these folks need to be represented by the Army combat units, right? And so now you have a infantry officer that's in charge of these service members, where before the medical department was in charge of them. And so it just changed that even in something as pretty similar as the Army is, that having that representation actually affected and helped the care of that service member. And so if something like the Army can do it, then we need to consider how our communities can do the same.
Well, just in closing remarks, I want to make sure every panelist has an opportunity to say their closing remarks, any additional comments. Also, if there's any last minute questions that come through, let us know in the chat. Ken, let's start with you. Final thoughts in regards to this topic.
Following up with Shani about the idea of inclusion, the idea of listening to each other is a really important skill. And sometimes we can be distracted by what we're seeing and not what we're hearing. So give you an example, in a waiting room, you can see the front desk looks very appropriate. They're all nice Hispanic, nicely prepared, civil people who are working together, sometimes talking in Spanish. And then you look across the counter at the waiting room, and it's looks like little United Nations. You've got Black people and Russians and Tongans and all sorts of people. And so the idea of how do you match and listen to each other, the Hispanic model that I was just describing is not that uncommon in healthcare. We have those on the night shifts in some places where we have Filipino nurses. We have them in various kind of work environments, a lot in the service areas. But listening and communicating in a common language, doing inclusion that includes the minorities of the minorities. So we had to work diligently to make sure that we're not just thinking that diversity has to do with our Hispanic workforce or the Hispanics we serve in the community, but the other 40% of our population that don't speak any of these language, and we're looking for doctors and nurses who can talk to them without translators in regard to their particular care environment. So I think that the art of listening is going to be something that we should be working on as part of our inclusion, our structure, and our corporate culture. Some of that is maybe sounding a little convenient when actually the public is expecting us to be standing up and making pronouncements. I think I saw an article last week that those who, the CEOs who talk about Black Lives Matter and diversity and inclusion and equity are some 5 times more trusted. So how do we work on trust when we listen? How do we express our listening and our responsiveness to this? So I think this is complex. It's not that it's in our textbooks from healthcare administration. It's actually somewhat new learning and how the human brain works and how our culture is trying to catch up on some of the social sciences in comparison to some of our hard sciences. We're actually better at doing diagnostics than we are therapies. And I think we're actually better at finding disparities than we are at fixing them.
Well said, Ken. I definitely encourage all leaders on this event to make sure they do a better job listening, you know, and showing both empathy as well as sympathy to the folks and the people we interact with and the patients we serve. So well said. Thanks, Ken. Bill, final thought from you?
Yeah, I think that this has just been such a nice discussion, and I want to thank everyone for having me. I think one of the things that I'm hearing come up again and again is just how complex this issue is and how rapidly it's changing. I mean, just over the last 6 months with such significant changes in modality for how people accessing care, with such significant potential changes in the healthcare insurance marketplace over the next year. I think we're all just going to have to stay really tuned in to understand these issues as they evolve over the course of the next year. I think there's a lot of decisions to make.
Any final thoughts from you?
I think, Andrew, you're calling on me. You're getting a little faint there.
Oh, Phil and then Shawnee. Yeah, go ahead, Phil.
I just wanted to thank my fellow panelists, Shawnee, Bill, Ken, and you, Andrew, for a really stimulating discussion. And I think the first step in any journey is kind of, recognizing, what's ahead and recognizing the opportunity. And so the fact that everybody's taken some time out of their busy schedule to talk about something that I think is crucially important, I think is wonderful.
Shadi? Anything from you, Shadi? Are you good? Good?
Trying to unmute, sorry. So again, I always said my 7-year-olds know how to unmute better than I can on Zoom. But no, again, appreciate the conversation. Thank you, for ACHG hosting this event this evening. I love the discussion in the chat. I was actually taking some notes like, I need to learn a little bit more about that. So again, very good session, and I look forward to hopefully more next year.
Well, thank you so much for your sharing your expertise, for being vulnerable, in regards to sharing, being transparent in regards to what your organizations are doing. Just to close, I wanted to share really from the Robert Wood Johnson Foundation, really their definition for health equity, which they say, health equity means that everyone has a fair and just opportunity to be as healthy as possible. I think it's simple, it makes sense. Take that with you as you go back to your organizations, as you go back to your daily lives. Don't be afraid, to speak to someone who maybe doesn't look like you or sound like you or speak the same language, right? Or even have the same insurance plan. Make sure you go out there and, overcome fear and really, help one another, help each other, reach out to other organizations to figure out how we can solve that issue, which according to this group from a prioritization standpoint is, the insurance coverage issue. So with that, I'm going to turn it back over to you, Darielle, just to wrap this up. And then I think, Jennifer, you had a couple closing statements.
All right, thank you, Andrew. And I'd like to thank you all for your active participation tonight. I've thoroughly enjoyed, reading through the chat, and the questions were definitely engaging. A special thank you to our panelists, Ken, Philip, Shani, William, and thank you, Andrew, for moderating. Excellent work, creating excellent discussion. Few of the items that kind of stuck to me were food insecurities. My wife had participated in handing out food to the unemployed and the needy when COVID had first hit, and the lines were just exponentially longer than what we would normally see. Kind of hits home quite closely. Affordable healthcare services, especially with rising unemployment. I've been watching, the court cases going to the Supreme Court in the Obamacare and Affordable Care Act, definitely on my radar. And the California Exchange, how affordable is that going to be for our unemployed population? And even the services they do purchase with these high deductibles, that is definitely on my radar as well, as far as healthcare policy. And finally, how important it is inclusion. I mean, just across the board, inclusion in all areas, and how important it is for us to enable healthcare access for all. I work in a children's environment, and, I would never deny a child based on insurance, and that just kind of, sticks in my side a little bit when I hear, things like that happening, within the healthcare industry. Not with this group, of course. So for our participants, I fully encourage you to share your feedback in the post-event survey that will be going out. And please, provide some content or context as to what kind of content you would like to see for this coming year in 2021. That would be exceptionally helpful for our California Association of Healthcare Leaders to put on future events. And lastly, we'd like to thank our sponsors. They are the ones that have enabled us to put on this virtual series. We were originally going to do a 2-day CAHL, and thanks to our amazing board members that are present, they've been able to pivot and offer the Congress virtually through a series of events. So thank you for that. And without any further comments from me, hand it off to Jennifer.
Thank you, Darielle, and just want to echo all of your thanks to all of our participants, the moderator, the panelists, all of you. It's been fantastic this evening. So I want to just give a couple of closing notes. Darielle did mention the evaluation, so we hope that you will complete that. You can do that by the same way that you came into the learning management system tonight to access this course. You can also access the evaluation from that same area. You can also, anytime within the next week, go back to your My ACHE page on our website and click on My Online Learning and go to Access My Courses. And you can get back to that evaluation at any time within the next week to complete it. In the same location, within 48 hours, the recording of this session will be available. And within 2 weeks, your 1.5 hours of face-to-face credit will be applied to your record. So with that, I'm going to go ahead and conclude our session, which is copyrighted in 2020 by the American College of Healthcare Executives. All rights reserved. So thank you, everyone, for your participation this evening.
Thank you. And Semper Fi to all you veterans.
Thank you.